I'd like to thank members of ASMBS and Dr. Mike Edwards for inviting me to participate in this robotics symposium. My topic and my disclosures. I do teach for Intuitive, and I've been known to help name robots, if not actually help decorate new arrivals. So I mastered the laparoscopic technique and then decided to walk away from the table, take off your shoes, and sit down. You got to admit, I look pretty happy sitting in the console corner. In the interest of time, I'll address 3 issues where I feel robotics has an advantage over laparoscopy. And I know that last one might trigger some fighting words. So ergonomics, a SAGES survey compared to 1999 where 8 to 12 reported pain. In 2010, 86.9% of surgeons reported symptoms of physical discomfort with laparoscopy. And frankly, this is accentuated in a surgeon that is 5'4" with 6.5 hands. Now, in that interval of time, do we become delicate flowers? Or do we start feeling the impact of years of laparoscopy on our bodies? Does the physical discomfort impact our surgical technique or our outcomes? And would you be okay being the last case of the day on your surgeon's schedule? The improved ergonomics with robotics has been discussed as far back as 2003. And ergonomics encompasses not just a physical aspect with which we are familiar, but also the cognitive and sensorial ergonomics. They theorize that given the 3D vision, the increased degrees of freedom, all of which help improve the surgeon's skills and dexterity as well as the comfort of the surgeon, that this could have far-reaching implications for the patient with improved outcomes. It's really time to improve our work environment. If my initial interest in robotic transition from laparoscopy was purely selfish, the other reasons were less selfish and not evident initially, like reproducibility. How can I make sure that my surgeries go well every time? And why does a robot allow that versus laparoscopy? Partly it's all about control, and don't tell me that surgeons aren't control freaks, but if we can control during any complex surgical procedure, the camera, the stapler, and control 4 arms, we control the flow of the case. And this allows us to have less variables which can adversely impact our outcomes, and it includes less reliance on trained surgery assistants. Reproducibility is also evident across a wide range of BMI in conversion or revisional procedures versus primary. Taking high-risk patients, which we'd agree that higher BMI patients are in this category, and comparing them to lower BMI patients, this study, looking at robotic gastric bypass, found no difference in patients with a BMI over 60 in terms of their hospital stay complications, no conversions to open or laparoscopy, and no anastomotic leaks, although none were noted in the lower risk group as well. Another review of high-risk group of patients undergoing revisional surgery, laparoscopic versus robotic, specifically found that with stapled procedures, the robotic approach had a shorter length of stay and no leaks. Operative times were equivalent. Robotics also has the advantage of a shorter learning curve. The learning curve of a laparoscopic gastric bypass has been shown to be 100 cases. With a robotic platform and an experienced laparoscopic surgeon, it's 14 cases. But what about a novice surgeon? In this study, novice surgeons perform drills faster robotically than the expert laparoscopic surgeons. And this seems to level the playing field between surgeons of different skill levels. After all, our goal is improved outcomes for our patients. The immersive virtual environment with a robotic platform offers advantages over a laparoscopic trainer regardless of the procedure, but it is probably more notable with complex procedures such as gastric bypass. The VR simulation programs being developed and remote mentoring are also best done with robotics. Outcomes. This study looked at laparoscopic versus robotic Roux-en-Y gastric bypass and found lower complication rates that were significant in the robotic group versus a laparoscopic. And interestingly, the robotic surgical times were also shorter. Specifically, they also used the same operative techniques with a linear stapler in both groups and had a trend toward decreased leak rate, hemorrhage, and reoperations. This review of robotic bariatric surgery included 8 studies regarding robotic versus laparoscopic gastric bypass, and one study demonstrated a lower length of stay and also a lower leak rate in another study for robotic gastric bypass. Now, what about my own experience? First of all, I do primarily robotic gastric bypass with about 20% conversions. But looking at all cases, there was 1 transfusion in 5 years, 1 open conversion in 5 years, and a 0.4% leak rate in all comers. Our length of stay was decreasing And in 2020, 42% of our patients went home, with 45% of those same-day discharges being gastric bypass. So in summary, robotic ergonomics are improved over laparoscopic with gastric bypass or any procedure, and the reproducibility robotically is evident across complex patients and facilitates training. And there are low complication rates in both approaches, but there is a trend toward a lower leak rate, bleeding, and length of stay with robotics. Thank you.